presentation screen. Yes.
Reduce it now. Okay.
Yes, ma'am. We can see it
Okay.
now.
So it is basically, it has been ossiculoplasty. I never knew I could bring this sense of music in our surgeries, because art and science go hand in hand. And for me, ossiculoplasty has always seemed like a symphony. Like three musical instruments playing together create such beautiful symphony. And if we orchestrate all the ossicles or the processes in a way, they bring such beautiful hearing to the patient. We can restore any level of conductive hearing loss. We can restore by doing a good ossiculoplasty. Lately, what I've been seeing that regarding cochlear implant, kids are born without hearing and speech, and then we go to all extent like spending lakhs and lakhs of rupees for cochlear implant, because main thing is to give hearing to the child. So by unnecessarily, without spending a single penny, we can add that hearing to the patient. And believe me, this confidence which I impart to my patients, that I am going to heal your ear also, and I am definitely going to give you certain good level of hearing. So that is how the bond between the patient and me forms, because he is reassured that if there is a conductive hearing loss, we are going to get the result. And happens through three liver actions. One is catenary. The movement of ossicles around a axis makes a special kind of a movement that transmits all the maximum sound to the stapes and footplate. Third is the hydraulic lever, which is due to the difference in area between the big tympanic membrane and small footplate. All the sound gets transmitted localized here, and the theoretical final gain is 34 dB, which is quite a lot, though actual middle ear gain may be between 20 to 25 dB. So every case requires the this thing, good ossiculoplasty. Regarding how the most important investigation before we go ahead with the surgery is the CT scan, HRCT temporal bone, axial cuts. I am sharing few important cuts where our focus is mainly on the ossicles. Every case, you won't believe, even my sister, the staff nurse who washes with me, can tell me, मैडम इसका तो इनकस गया हुआ है, इसका तो स्टेपी सुप्रास्ट्रक्चर नहीं है. Imagine, because it is so simple. This is the superior cut where it is antrum. You can see the body of head of the malleus and body of incus. Next lower cut is where semicircular canal is appearing. This is ice cone appearance, like ice cone. This the top is with the head of the malleus and the cone is with the body of incus. And here it is the fossa incudis, where the short process of incus is sitting. This is a normal case. Next level lower down, the cut section of the manubrium of malleus and the long process of incus is there, because still the vestibule has not appeared. Now that vestibule has appeared, we can see the arch of stapes there. This is the incudostapidial joint, the manubrium of the malleus. This is a better picture for that. We can see the whole arch lying so beautifully. It should all be intact. So this is the area of focus. The moment you read it, a case of cholesteatoma or any disease where we can give correction to the ossicles. Now I've taken two cases. One is this, where there was a sorry, this is the coronal cut, that was axial. Coronal cut is from posterior to anterior always. This is vestibule, superior semicircular canal, lateral semicircular canal. This is facial now, second genu, and here is the appearance of the ossicle. Next, you can see this is the vestibule footplate area and stapes suprastructure and the appearance of long process of incus. This is clear cut long process, and this is slightly curved as the malleus with the tensor tympani tendon. So these four cuts in coronal section. Now this is a case of meningoencephalocele mastoid. You can see there is a big meningoencephalocele filling the middle ear. The bone tegmen is gone. But because this is not a cholesteatoma disease, the ossicles are absolutely intact. So disease, ossicular erosion doesn't depend on the gravity of the disease. It is the level which disease. Meningoencephalocele doesn't cause much defect to the ossicles. Here you can see the complete stapedial tendon, incudostapidial joint, and stapes. So in the next case, which is a cholesteatoma disease, here you can see this is facial nerve, uppercut, first genu, tympanic segment, no ossicle at all. And this picture you can see this cholesteatoma is sitting on the footplate. Here there are no crura, no stapedial suprastructure, no ossicle at all. So this was a quite extensive disease. So this is how you have to read all your CTs. Now coming to the ideal prosthesis. If we take ideal prosthesis has to be biocompatible, biosterile, it should be the right weight, it should have the mobility, it should have the finesse of the original ossicles. So we are still looking for that. Some ossicle has got a different property, the other has got different. So we have to pick and choose and give the best. And believe me, material becomes secondary when you know how, where, and how to put it, and then we can extract the maximum hearing. So coming to the choice of material, if there is an incus present, I will always pick up incus. That is the turupka ikka for me. If it is there, I will definitely use it. Keeping in mind it should not be affected by the disease. There should not be erosion because cholesteatoma erodes through the bone, and if it is affected by that, we shall not use it. Then second is head of malleus, bone or cartilage. Homografts I used to use few years back, and then I found certain cases having small, reactions. And it had to be really very, we have to be particular. We have to get a consent from the patient. And that is a laborious thing. And I have stopped totally using it. I would rather use a synthetic process, which is Teflon, titanium or bone cement, which I'm going to show you. So before I go to every situation, I am sharing what is all over available Austin cartouche classification. It has been divided into 4 groups. Rest 3 groups I am not going to take up because for 45 minutes I can only take up these 4 groups. I'll show the videos also. So group A, for them Austin cartouche, incus was nothing. For me, incus is everything. So I will show what I have created my classification. Group A is malleus is present, stapes is present, like this. Group B is malleus present, suprastructure absent, footplate is present. Group C is malleus absent, suprastructure stapes present. And group D is malleus is absent, suprastructure is absent. This is footplate. So you have to methodically, mathematically know how, where, how much to be put. And believe me, it gives accurate, very accurate results. Rest 3 groups are: group O is intact ossicular chain, group E is when ossicular head fixation is there, and group F is footplate is fixed, as we do in stapedotmy cases. Hello, this is the classification what I have configured. For group A, I have made incus present or absent, where lenticular process is necrosed, but incus is usable.
Yang
And
sudah nanti kamu besok
usable.
masih ada plastik jam 7 tuh.
Group B is when this is
Kan nggak tahu juga bila ada.
please, somebody has put the mic on, kindly put it off. So second group is malleus is present, suprastructure absent, footplate present. Again, incus becomes very important. In group A and B, wherever there is malleus, incus plays a very important role. But in group C, when the malleus is absent, suprastructure may be present, but incus cannot be used because there is the handle of malleus is very important in making that liver action for interposition graft. So if malleus is absent, then incus is of not much use. There we use the other prosthesis. Group D, again, malleus is present, suprastructure is absent, but footplate present. And rest, the groups are same. Group F is again divided into group type 1, where malleus incus are present, but footplate is fixed, like in stapes, autosclerosis. And 2 is malleus present, incus absent. 3 is malleus absent, incus absent. So we are going to take above 4 groups because that is another long chapter, which I can take next time. So coming to group A, malleus is present, stapes is present, incus is present, but there is a partial to complete necrosis of lenticular process, not long process. Long process, at the tip of long process, there is lenticular process, which has got a shaft and a disc. That shaft gets the minimum supply from the blood supply. So there's the earliest to go. So mainly erosion starts at the lenticular process. So coming to first surgery. Okay, there is I will show you this is a minimum less than 50% erosion of the incudostapedial joint. We take away all the mucosa, bare this joint and put a perichondrium over it just to regain the vascularity. That is how we. there is partial necrosis of lenticular process of incus. In such situation, we just clear the granulation tissue from the affected part of ossicle and place a piece of perichondrium over it to increase the vascularity and prevent further necrosis of long process of incus. Temporalis fascia graft is placed lateral to the incudostapital joint and medial to the handle of malleus. So we always keep it medial to the handle of malleus if it is available to avoid the lateralization of tympanic membrane. So minimum necrosis is handled like this. But if the necrosis becomes slightly more, then we can use, there are many variations what we can use. This is bone cement, which the dental people use. It has got a powder and a liquid. We have to mix the two, make a paste, and we have to immediately apply it because it takes 3 to 5 minutes for it to get solidified. Before applying that, we have to clear all area from the mucosa. It should be bare bone. All the important structures should be covered, and we put dry gel form to avoid all the structures. The neural and vascular tissue should be away from this bone cement. This gives really tremendously. This is the left ear of the patient. There is partial necrosis of incudostapital joint. Gel foam pieces soaked in saline and adrenaline are placed around the joint in a way that it covers all the surrounding structures. Then the bone cement paste is dropped over the joint in a way that it does not touch anywhere else. One by one, all the gel foam pieces around it are removed, and this is kept like that for 5 minutes because a dry medium is required for the cement to set in. After that, we will check the round window reflex, which you can see is there. Then we cover the joint with either a piece of perichondrium or a piece of cartilage, and then place the temporalis fascia graft lateral to the incudostapital joint assembly and medial to the handle of malleus. So bone cement is safe if we are not letting it come in contact with any important neural or vascular tissue, and it sets in quite fast. So I have been using it in 2-3 situations. I will show through the videos only. Now, if the gap is, the lenticular process is totally gone, and if there is a gap and patient is affording, then we can use angular prosthesis. Angular prosthesis is from Kurs, and it costs around 25,000. So if patient is able to pay, the airborne gap reduces to almost zero. Right here of the patient, there is necrosis of long and lenticular process of the incus, and stapes is intact. We have chosen angular prosthesis for this situation. This prosthesis has a bell on one side which fits on the head of the stapes, and 2 clips which are placed around the residual long process of the incus. After placing the prosthesis, one by one, both the clips are crimped around the incus with the help of a fine crocodile forceps. After that, the mobility of the ossicular chain is checked. Now, floor cartilage graft is harvested and trimmed into 0.5 into 5 into 5 millimeter size graft, which is placed lateral to the angular prosthesis so as to avoid its extrusion in future. The temporalis fascia graft is placed lateral to this assembly. So just to keep this thing in mind, though these titanium and Teflon are both bioinert and biocompatible, still we always must cover it with a thick thin split thickness cartilage so as to avoid its extrusion. Now, if somebody cannot afford such a costly, what to do? You take a slice of cartilage with extra perichondrium on one side, and it can be placed between the incus and stapes, and the extra perichondrium can be wrapped around the long process. As I am showing you, this is the cheapest and the simplest method. Anybody can choose to do. Right here of the patient, there is gap between incus and stapes. Now we prepare the cartilage graft in the manner that we leave an extra perichondrium on one side of the graft. After placing this cartilage graft, the extra perichondrium is wrapped over incus to increase its vascularity and prevent further necrosis in future. And this wrapping of extra perichondrium makes the assembly more stable. So now, once we go beyond lenticular process, now the long process itself has got eroded and the gap is more than 3 to 4 millimeters, then we cannot put, because very thick cartilage may not work. So we will take out incus and use it as interposition graft between the handle of malleus and head of the stapes. But many a times this head of the malleus needs to be cut for the free mobility, because the disease pulls the handle of malleus anterior-medially, and to bring it back to sit on the interposition incus, we need to do certain maneuvers, like you can see in this case. It's a case of left ear canal wall down mesoidectomy. Incus with eroded long process has already been removed. Head of malleus is cut for free mobility of handle of malleus. Now the incus is reshaped for interposition graft. In place of long process, a pit is created which sits on Stapes' head. Then, on the opposite side, close to the tip of short process, a groove is drilled for malleus handle to fit in. This assembly is closest to the normal ossicular assembly, as the lever action of the ossicular chain is well maintained. Finally, the round window reflex is checked. So this is how you could see a canal wall down. Now, in this case, it is a canal wall up case. You see this long process of incus is already gone. Incus is being taken out. By removing the incus, we help the patient in healing, getting this healing fast because the patency is nicely achieved. Patency between the mesotympanum and epitympanum. So after removing the incus, again we drill away the long process. In that place, we create a groove that sits on the head of the stapes. And on the opposite side, short process of incus, we will create the groove for the handle of malleus. So very simple. There are ossicle holding forceps also, though because I've been in so much, so many cases done, I take the simple artery, worn out artery, which has got the lock is not very strong. That artery I take and hold the ossicle in that. Now you can see, this is one of the, incus gives the best result, and I have seen AB gap reducing even up to the 5 dB. And this is where I can show the handle of malleus is too much anteriorly placed. How to correct that? I was trying to bring the incus malleus over the groove what I have created, but did not get the right assembly, and incus kept pushing medially towards the promontory. So first I deepened the grooves so that the handle becomes more snugly fit. You can keep taking out incus and create the right grooves there. Still, I was unable to do that. So I am now breaking the anterior malleolar ligament so that the handle of malleus can be pushed back. You see, we have to be careful because the chorda tympani crosses through that and we should not be harming that. So now this just see such beautiful assembly because the malleus is free to be moved and it will sit very nice. Here I can see that maybe head of the malleus is also blocking the way. The patency can be achieved more when I take away the head of malleus. The important thing is malleus is attached to the surrounding bone with 3 structures: anterior malleolar ligament, superior malleolar fold, and the tensor tympani tendon. Even if we protect single one of them, the malleus is not going to go anywhere. So mostly I protect the tensor tympani tendon. That is the strongest. I can any day break the anterior malleolar ligament or the superior malleolar fold. See how beautifully it is moving. Okay. So this is on you, how to bring the malleus back into the right position. I even went to this, created this figure of 8. And in place of groove, I created even holes. Once you develop this finesse of doing work, drill, sculpting the incus, you can go to any extent. Just see, in place of groove, I created 2 holes, and the one hole goes through the long process of incus, the other hole sits on the stapes. This is the, when I have time someday, I keep doing it. I put the music on and do it like as I'm doing some painting on the canvas. It should become an important part of your surgery. And now we are coming to group A, where incus is not there, but malleus and suprastructure of stapes is there. So now, because we don't have incus, we have to use certain prostheses. This is called partial ossicular replacement prosthesis. For here I'm using titanium. We can use Teflon also, depending on how much the patient can pay. Both are giving good results, though both are biocompatible. Titanium top is slightly more fine and gives slightly better hearing to the patient I've seen. This should be sitting absolutely stable on the stapes head. It should be in touch with stapes head and tympanic membrane only, or the cartilage in between. We always put a split thickness cartilage lateral to the bore, and just keep it in mind. The height of middle ear is around 4 to 4.5 millimeter. For the good working of ossicular chain, this height or the middle ear space should be maintained. For that, suprastructure plus pore plus cartilage should measure around 4 to 4.5 mm. Left ear of the patient, canal wall down mastectomy has been done for cholesteatoma disease. Malleus present, stapes present, but incus is necrosed and absent. So we opt for titanium PORP. 2.5 mm sized titanium prosthesis is required in this case. After preparing it, we shift the prosthesis to middle ear. The slit bell of the prosthesis fits on head of stapes, and a 5 into 5 mm sized partial thickness tragal cartilage graft is prepared and placed over prosthesis to avoid its extrusion. The placement of the prosthesis and cartilage piece is always rechecked after placing the temporalis fascia graft. This is very important. I'll keep showing you in various videos that always pick up, because all these manipulations could have made this assembly unstable. So whenever you put the tympanic membrane or the fascia graft, we must always check it. Now this is the cheaper version of titanium top. For me, if head of malleus, which is not diseased, is present, head of the malleus is the last one to go. The first one is the lenticular process, last one is the head of malleus. So head of malleus can be put as a columella graft over head of stapes. So here you see this head of stapes present. Now this is tragal cartilage with extra perichondrium. This has been done to reconstruct the posterior canal wall. Patency checked. Head there, just put a groove in the head of the malleus. Let it sit on the stapes. So no scope of extrusion, nothing doing. This is normal stapes of the normal ossicle of the patient, and gives the finest results. Even in these cases, I have found airborne gap reduced to up to 5 dB only. Now coming to group B, where malleus is present but suprastructure is absent. So incus usable is there. Here I will show you. Again, we will cut the anterior malleolar ligament because the handle of malleus has gone quite anteromedially. Incus is reshaped. Now it will be put between the malleus and the footplate. There is no suprastructure. So we will design it differently. I'll show you in the video. And where that case, we had to take height to 2.5 because suprastructure of stapes was present. Suprastructure of stapes is around 2 mm height, and 2.5 we add on by putting the PORP. Here we will be creating the 4.5 mm depth, and the shaft here should be perpendicular to the footplate. Left ear of the patient, canal wall up mastectomy already performed. Handle of malleus found medialized and anteriorly located. So anterior malleolar ligament is cut and handle of malleus is released. Incus is used as an interposition graft between malleus and stapes. In this case, the technique of sculpting the incus is a bit different from the previous cases. The long process of incus is first drilled away completely. Now a deep groove is created on the articular surface of incus, which will go under the handle of malleus. The short process of incus is slightly trimmed into a shaft, which finally sits on the footplate. In this situation, we need more height than distance between handle of malleus and stapes. So the short process gives height to the middle ear, and groove keeps handle of malleus stabilized in new position. Finally, the temporalis fascia graft is placed lateral to the ossicular assembly. We always lift up the temporalis fascia to check the final placement of the ossicles. So now this is another case. Here I am using bone cement for interposition. It's a case where incus is shaped as interposition graft between footplate and handle of malleus. So handle of malleus is relocated posteriorly by cutting the anterior malleolar ligament. Most of the cases require it if it is a chronic. The reshaped incus with short process sitting on footplate is being placed between the footplate and handle of malleus. We will use bone cement to make the assembly more stable. For that, dry gel foam pieces are placed in middle ear for dry surroundings. Bone cement, which is prepared like a paste, is then applied over the assembly. The extra bone cement can be sucked with a suction tube. Once it dries up, which takes around 5 to 7 minutes, all the gel form pieces are removed from the middle layer. The round window reflex is checked. We must make sure that the bone cement does not touch the footplate or any exposed neural tissue. And then finally, a split thickness cartilage with perichondrium is placed between the assembly and neotympanum. So now coming to next situation. Group B, where incus is unusable, suprastructure of stapes is absent, though malleus is present. So here we are using torque in place of cork. There was suprastructure present, here the suprastructure is not there. So 2-point stabilization technique is there because the torque shaft is circular, whereas this footplate is oblong. We need to have some stable platform on which the torque should sit. So a cartilage shoe is prepared for the footplate and one cartilage is placed lateral to the head of the torque and the whole height should be around 4 to 5.
As incus is completely necrosed, titanium top is to be used on the mobile footplate. After measuring the height of the middle layer, 3.25 millimeter size titanium top is prepared. Cartilage shoe is made with the cartilage punch. The shaft of the top is fitted over the cartilage shoe and then shifted to middle layer. The prosthesis with the cartilage shoe is gently placed over the footplate. The outer dimension of cartilage shoe should match the dimension of the footplate to make a stable assembly. Then a partial thickness cartilage graft is placed lateral to the head of the prosthesis, and this is what we call a 2-point stabilization technique. Finally, the temporalis fascia graft is placed lateral to the assembly, but we always lift it up to check the final placement of the prosthesis.
So this is why this is the shape of the footplate and this is the shape of the shaft. This cartilage shoe is prepared with a cartilage shoe maker. So this is placed on the footplate and the assembly becomes so stable. Another case where this posterior canal wall reconstruction also. Only footplate present. So these are better than the this boomerang shaped cartilage. The ossicles are the best. After that, we have to choose between this cartilage and patient is able to pay, then I will use this titanium top. This is the sizer. We measure the size and then put the right Teflon, so titanium top into the slot 4 mm is this I have put it in. Extra shaft is cut away. Then there's the size is placed there. We need a cartilage shoe. Many a times, at times it slightly breaks on one side. It is okay because basically we need a stability for the shaft of the top. Because again, we'll be placing the cartilage over it. The assembly should be stable and it should not keep, rotating here and there. There's the posterior canal wall reconstruction with the cartilage. These are middle ear aerobics. Once you get addicted, hooked to it, you will do it in every case. So slightly more time from you, but the patient gets all the benefit. Now group C, malleus is absent, so incus present or not present doesn't make any sense. So here I am showing you that suprastructure of stapes is present, no malleus, no incus. So we create a groove on the annulus just opposite in the maximum diameter of the circumference. There we put the, drill the groove in the bony annulus and put a cartilage graft between the annulus and the suprastructure of stapes. Very simple, but it needs to have a very thick and stable cartilage because it has to stay there for a very long time. So this is slightly bigger video to show you how we do a canal wall down, and this is where we have done a canal wall down mastoidectomy. This is the thinning of facial ridge in progress. We have only stapes. All the cells of the surface of the mastoid cavity are being cleared. A milky white cell-less cavity is achieved. the facial ridge has been lowered, quite sufficiently lowered and thinned. All cells need to be cleared because we are going to do obliteration of the cavity. So now we'll lift the tympanic membrane, create a groove there, and place this cartilage. To make the cartilage more stable, we will create further groove in one edge of the cartilage. I'll show you how. This is the obliteration of cavity. Now by lifting this tympanic membrane, I am creating the space for the cartilage to settle in. This is slightly bigger. Don't think twice before taking it out. You have to make, this is the groove I am creating on one side, which sits on the stapes and makes it more stable. Because this is just a piece of cartilage. We have to put it nicely on both the ends so that it doesn't move. Many times I'm doing revision surgeries, I have seen this cartilage has moved from its place. Again, round window reflex. This is a piece of cartilage to reinforce this part because there may not be a reflection pocket later on. This is the first layer with cartilage pieces. Then I'll put bone dust and then final muscle rotation flap. So I obliterate the cavity in 3 layers and reduce its size tremendously. This is one case just to show you how other factors are also important. Other than doing a good ossiculoplasty, we have to do a good obliteration. We will see I have not removed the mucosa from the epitympanum because now this part is going to play the role of ventilation and middle ear. There's a big fascia being placed there and the residual tympanic membrane is spread on that. So this is one of the cases just to show you. Now group D, suprastructure is absent. Here we will use a boomerang cartilage. Before it was a suprastructure of stapes present. Here the suprastructure is not there. So I'm creating grooves for the reconstruction of posterior canal wall. This C-shaped cartilage sits so beautifully. This boomerang-shaped cartilage gives better results than the flat which sits on the flat cartilage which sits on the suprastructure of stapes. This posterior canal wall closest to normal circular cavity. This is canal wall down. Groove being created. Cartilage, if it is not circular shape, then we can cut a partial thickness groove on one side to create that C-shaped cartilage. This way it creates the height of middle ear also. So boomerang cartilage gives quite good results. It has to be really thick and stable. Now, what is the most important part of the ossicle which we need? For me, the Malleus handle is used for catenary liver and impedance matcher because it creates a catenary liver by using the interposition incus. Incus for interposition graft and head of Malleus as columella graft I have shown you in few videos. For me, Stapes suprastructure is least important. I have conducted all these, all the cases and compared the results. Stapes suprastructure is not making much of the difference if we have done a good ossiculoplasty. So, Malleus handle and incus are the most important ossicles being used. Then I use cartilage or synthetic grafts as columella graft, and cork gives better result than top because it creates a more stable assembly. Now, regarding important points of placement of prosthesis. It has to be really, really very precise. Anything what you use, even a head of Malus gives good result if you're doing it with precision. When we place a ossicular prosthesis, placement is without tension before placing cartilage lateral to it, but it becomes under slight tension after placing cartilage lateral to it. So that means our ossicular prosthesis, it is about the columella ossiculoplasty. The graft should, when I place cartilage lateral to it, it should be slightly more lateral to the level what we are expecting, because it settles down later on. It should be at right angle to the footplate. Bone cement, if used, should be only between two ossicle ends. Cartilage shoe is used when we are going to use torque for 2-point stabilization. Malleus reposition or transposition is mostly required because disease leads to medial and anterior dislocation of the malleus. Annular ligament, when we are using this footplate directly for the ossicular prosthesis, that has to be respected. Our movement should not be that jerky that it gives injury and causes some inner ear damage to the patient. Important fine points are round window reflex to be checked after final placement. Patency of attic before and after placement of prosthesis is always checked, because the prosthesis or the ossiculoplasty may not be that bulky that it blocks the attic, leads to blockage of patency, and then eustachian tube patency should be checked. Height of middle ear with ventilation to be maintained. In canal wall down, keeping mucosa of epitympanum intact. Rechecking of ossiculoplasty after temporalis fascia graft placement, as I've shown you in many of the cases. Chances of failure are when there is resistant infection persisting. So I always repeat in my lectures, please, if it is a chronic case, wait for a few days, get a culture sensitivity done, start the real antibiotics, because most of the times in chronic cases, it is either Pseudomonas or MRSA or any infection. Sometimes it is gram positive and we are unnecessarily putting the patient on gram negative. So it has really helped me a lot. And while healing also post-operatively, I don't mind repeating culture sensitivity as many times as possible. If there is a mucosal erosion, then it can cause the adhesion, and eustachian tube function also leads to failure. So these are the post-operative results. Then 1 or 2 videos for revision mastectomy as a revision ossiculoplasty. See how beautifully this posterior canal wall reconstruction is there, and incus interposition is so nicely visible. This is placed cartilage. This is the boomerang or cartilage there used between the footplate and the annulus. So these are certain cases. They really heal well. So this is one of the case, as Dr. Gauri said, you must show certain CT scan comparisons. So this was a case of a very extensive revision cholesteatoma surgery. There is no ossicle other than the head of the malleus. Nothing is there, you can see. But when I see closely, there is this arch of Stapes present on the vestibule. So when I did the surgery, there was this cholesteatoma. Just see, this is the, I don't know whether you are able to see this right side, the hearing loss is up to 80 dB, and here it has improved like anything, because I used a cartilage graft over you can see this is the residual stapedial crura, and this the cartilage, this tragal cartilage placed there. So it worked very well. There you can see the titanium piston. I hope you are able to see this is the titanium piston I placed in one of the cases. This is tragal cartilage graft. So keep calling your patients, take the post-surgery this thing from them and keep improving on that. So certain unique situations. First thing is how we select the case. Worst ear is to be first for symmetrical hearing. Selection is based on preoperative audiometry and potential to regain serviceable hearing. First thing is that we are able to give serviceable hearing. If it is a sensory neural hearing loss, then we do ossiculoplasty to maintain the middle ear height, but we tell the patient that we may not be able to give you good results. But if there are both ears available, then worst ear is done first for symmetrical hearing. If there is a fixed footplate with tympanic membrane perforation, we do ossiculoplasty second stage. If there is Dead ear, as I told you, SNHL, then ossiculoplasty is done just to create middle ear space, use of right instruments, drilling of posterior sputum without injuring. That coda is important in every case. Try to protect it, because consider if somebody cuts our coda, how we are going to feel the taste, loss of taste on that side. So as much as possible, try to save dexterity around stapes area and middle ear aerobics, as I've already shown you. So this is a when there is a lot of adhesion in revision cases, mucosa gets traumatized, there it is eroded, and we have to use some spacer. So celastic sheet as spacer is used in mesotympanium, and one tail is created which goes into the eustachian tube. It allows the middle ear mucosa to heal and prevent adhesion between neotympanium and middle ear. This is one of the cases.
The right ear. After clearance of disease, the stapes was found fixed due to the presence of multiple layers of tympanosclerotic plaques around it. So very gently, layer by layer, all plaques were cleared from stapes and around. If we perform this step with patience, we can clear all the plaques, including the ones between the crura of stapes. Once all the plaques were cleared, a mobile footplate could be found, as shown by round window reflex. Usually, in extensive tympanosclerosis, the middle ear mucosa is either diseased or traumatized. So, to avoid formation of adhesions, a celastic sheet is placed in middle ear. It's cut in a manner that the tail goes inside the eustachian tube orifice and rest of it sits on middle ear mucosa. For ossiculoplasty, as there is no usable malleus or incus, a cartilage strip with perichondrium on one side was used as an ossiculoplasty graft.
This I've already
It's
shown.
placed between head of stape.
And this is the last but one slide which shows when do we do the staging of surgery. Why do we use staging of surgery? Because for ossiculoplasty, it allows the damaged mucosa to heal. Many times the mucosa is so much damaged that we need to wait for completing the ossiculoplasty. It heals. So failure due to adhesion, scarring, and fibrosis avoided. Better assessment of the position of and there is a better assessment of the position of tympanic membrane and eustachian tube function and middle ear space after healing. So what are the situations? One is when there is extensive tympanosclerosis with fixed footplate, as I showed you in this previous video. When there is a fixed footplate plus tympanic membrane perforation, when unhealthy mucosa around oval window or promontory, when presence of granulation, tissue or fibrotic adhesion bands are there, in extensive cholesteatoma cases where we are doubtful that we have been able to clear the disease or not. In cases of tubercular mastoiditis, we have to let it heal first, and the same thing in malignant otitis externa. In all these cases, ossiculoplasty takes a second stage. First, we let the middle ear or mastoid heal, and then only we perform the surgery. So this is one of the videos for that.
This is a second stage surgery for a case of extensive tympanosclerosis with fixed stapes. A piece of cartilage was used over the stapes in first surgery to maintain the middle ear space.
So this was done by me.
So this piece of cartilage is lifted and the stapes is found fixed beneath it. Posterior crurotomy is done and the superstructure of stapes is removed. A single layer of tympanosclerotic plaque was found sitting over the footplate. It was very gently peeled off from the footplate. After removal of the plaque, the footplate found mobile, as is shown through the round window reflex. The footplate seems unusually thin, so a piece of perichondrium is placed over it. Had it been a fixed footplate, stapedotomy with titanium piston would have been the procedure of choice. But in this situation, when the footplate was found mobile, titanium top was used as a prosthesis. The residual malleus is adding to the stability of the top. Finally, A partial thickness cartilage with perichondrium on one side is placed lateral to the prosthesis.
So I think I will stop here early because it is getting quite lengthy. I hope all of you are not asleep. So important criteria before I finish. Extent of ossicular chain damage is to be seen. Ossiculoplasty material. Technique is more important than the variety. Canal wall up, canal wall down, both you can give good results. We can divide that into primary or secondary surgery. Presence of resistant infection, granulations, let it heal first before going ahead with the ossiculoplasty. Middle ear mucosa and ventilation is to be maintained. Eustachian tube function is to be maintained. Thank you very much. I hope I have been able to impart right justice. And this is my book on ossiculoplasty. If anybody wants to go through it, they can buy it from the Amazon site. Thank you. Gauri?
Thank you so much, ma'am. It was indeed really eye-opening to see all the different conditions that you have covered, all sorts of permutation, combination of presence of each ossicle and how to tackle. I think I have seen your atlas. It has got beautiful pictures and beautiful demonstrations, and I think you've covered almost every query, but still there are some questions from the delegates. I will just go through them. One of the questions is that you have used partial thickness cartilage everywhere. Have you used a cartilage slicer for this?
When there is a beautiful cartilage slicer and we can use that, but as I am in the habit of, my hands have become all the instruments what extra we use. So I split it nicely. You put it on a glass, slide, and with a knife you can nicely slice it. Otherwise there is a slicer, but I have a slicer but rarely use it.
Okay.
It is easy to, just do a slicing and then it splits into half.
Okay. Ma'am, there's one more question. What is the long-term hearing result when cartilage is being used? I suppose the question implies that whether cartilage gets absorbed or displaced over the long-term period.
Definitely, ossicle used has a better longevity than a cartilage. But honestly speaking, if it has not been nicely done, there is adhesion around the incus or ossicle, then also it becomes useless. The mobility reduces. So again, I will say cartilage used with the right thickness in the right manner. Okay, it is just touching the two ends, so it really gives good result. The other factor which is causing the problem with the cartilage is middle ear ventilation. Cartilage fails because it pulls, if there is a force which is pulling the tympanic membrane inside neotympanum, it will keep pressing on the cartilage or bone. Bone can resist it, cartilage cannot. So that way, so more important, again, I will say more important than the material is the other factors. Middle ear patency, middle ear ventilation, eustachian tube. Few cases over the years I've seen where I ignored the nose because patient comes, he says, kar do ji, ear ka kar do. You see there is deviation in the nose or something. Please don't ignore it. That can cause failure rather than the material. But definitely if compared between the two, ossicle is slightly better than the cartilage. Then I became more this thing in choosing the right cartilage. I gave more importance to that. So, they also give good results.
Ma'am, one more question was that when you are using TORP or PORP, like the prosthesis, how much hearing gain have you, up to how much hearing gain have you seen, closure of the AB gap?
For the prosthesis, like TORP or
Yes,
PORP?
yes.
So if you ask me, the best has been with incus as interposition graft, but PORP and TORP have also given good result. I have got this whole data done, so I thought it may not be of much interest to you. Maybe I will show once I finish it. I'll just take 1 minute to show. So I've done a comparison of 800 cases. Let me show you if I am able. So if it is visible, like this. There were certain cases, 800 cases, where these are the situations where there was, I have already explained group A, B, C. So these were the cases for that. And this is the AB gap closure in different ossiculoplasty techniques. Is it visible there?
No, ma'am.
Oh, sorry, I will have to share it now. Just a minute. Just one slide and I will show.
Yes, ma'am.
Share.
Avni?
This is the last slide. So can you see?
Yes, ma'am, we can see.
So AB cap closure in different ossiculoplasty techniques. Incus, it was, this is less than, blue is more than 25, red is 15 to 25, and gray is 0 to 15 dB. So you can see here, incus between handle of malleus and suprastructure is around 60.3 percent got 0 to 15 dB. Okay. 65% in incus between head of malleus and footplate. Cartilage between suprastructure and now here you can see cartilage between incus and suprastructure of stapes. Okay, that is what I showed you, one split thickness cartilage when there was a lenticular bond. So that gives also good result. So worst was with cartilage between suprastructure and annulus. I told you between footplate and annulus gives better result because of the boomerang, it holds nicely. But if I use a flat cartilage, that is less stable and that is the worst. And also torp and porp give lesser than the original ossicles of the cartilage. Can you see the difference? We are focusing on the gray, 0 to 50 dB. Huh? So best are when we are using ossicles. Okay. Porp and torp are almost equivalent, but less than the original.
Yeah.
So this is 800 cases, but honestly, I am still going ahead. I've got a 2000 case series, and there I have configured like middle ear risk index. There is with by Austin and Kartush. I have created PSSI, post surgery this hearing index. So a new index has been created. I will be putting. There are 2000 cases. I have worked over up to 5 years the audiometry. So that will show which case has given the best results. So that is very important. So that is, it is a bulky data, so taking some time, but I'll be bringing it up in the coming months only.
Okay. Ma'am, another question is that how often have you faced extrusion of torp or porp?
It has been not very frequently.
And we've seen you are placing a cartilage between the drum and the torp, of course. So is there any way that you make sure that this doesn't get displaced?
Basically, again, for that cartilage, you really need to make a very nice thin cartilage, should be 0.5 mm. And in titanium, there is the shaft is projecting slightly above this. So creates a small groove, it sits nicely. So spending some more time, and a cartilage shoe is very, very important on the medial side. But if both the crura are slightly left, like suprastructure is gone, but the ends of crura is there, then you can place it directly. It will remain stable. Otherwise, you can put perichondrium, as I have shown in one case, if the area is small. But if footplate is flat and nice, big, then we have to use a cartilage shoe. And it gives good result. Few cases, definitely, you can say up to 10-15% cases, I have seen the destabilization also. So I take up those cases for second stage, replace it again. And my whole motive is to give hearing to the patient, and every patient, which means I will go to any extent to do that revision surgery also. But definitely torp porp slightly, because of the air current. So middle ear ventilation is the most important thing, middle ear ventilation.
Ma'am, you had shown one case of tympanosclerosis with ossicular fixation. So I suppose this next question is regarding that. The question is, if the suprastructure or the footplate is not mobile, would you always do this ossiculoplasty as a staged procedure?
If the suprastructure is not mobile, we can make that mobile. But a footplate is fixed, definitely we have to go for the second stage surgery. And many a times when I am reassured that tympanic membrane is formed, then I will try to take away the flakes of tympanosclerosis. Many a times I am able to clear the footplate. But few times it is not, and because that is another big, someday you can hold that second lecture for group F. Fixed footplate with malleus incus present, fixed footplate with malleus present, incus absent, and only fixed footplate. So there are multiple situations where if you see once, they will be able to know that anything can be done. If there is a conductive hearing loss, we can do correction in that. So that is the second part of the lecture, which we
Yeah.
will do someday.
Yes. This question is, I suppose, regarding a mobile foot plate. So there is a question that what are the chances of getting a perilimb fistula while doing an ossiculoplasty?
Oh, never. Annular ligament, if it is healthy, our movement should be so fragile that is to be respected. If we are finding a weak foot plate, as I've shown you, put a perichondrium over it. Then
Yes.
give respect to the foot plate and annular ligament. That is very, very important.
Ma'am, when you are doing the ossiculoplasty incus refashioning, what size burr are you using? That is one of the questions.
It is 1.6 and 0.8. So
Okay.
bigger, when I am drilling away the long process, it is 1.5, 6. But if I am making a groove there, that is either diamond or cutting 8 mm.
Okay.
8 to 1 mm, whatever.
Ma'am, like you're using bone dust in your cavity obliteration, there is a question that instead of using bone cement between ossicular ends, can the bone dust work in a similar fashion?
Washes away. It doesn't stay there.
Hmm.
It doesn't stay there. Either we use a glue.
Yeah.
Glue is a very good, but bone dust, bone cement is around 400, 500, and this glue is around 25,000.
Yeah.
But definitely glue is one of the best. But usually all of it goes waste just for one drop. So we rather create right grooves so that it holds well rather than adding on to that. So cement is used very rarely in few cases where I feel okay, it is going to add on to the stability.
Yeah. I think this was the last question we will take. The question is that if a retracted tympanic membrane retracts over the prosthesis, and then you are at a risk of extrusion, is there any role of a eustachian tube dilatation here to prevent
Yes,
this?
absolutely, absolutely. I immediately go into the nose, throat, whatever is causing that, eustachian tube dilatuboplasty. That plays a very important role. We use nasal sprays and try to find if a patient is allergic. Whole focus shifts there so that we are able to protect that assembly.
Okay. Ma'am, thank you. You have used the particular word that the middle ear aerobics. I think in your elegant hands, that aerobics is looking like a beautiful ballroom dance. If the beginners begin to do it, it will look like PT, but you are making it look like a very beautiful tango. So it's your skill which has really opened up eyes to what all is possible ossiculoplasty mein. I request Disha to do a formal vote of thanks and then we end the session.
Okay, thank you.
Thank you so much, ma'am, for giving us your precious time and explaining each and everything so beautifully, wonderfully. And hope we'll again have another talk with the remaining.
Group F. Okay.
Yes, definitely.
All the
definitely.
aerobics, rest of the okay.
Yeah, in the coming months, definitely we'll have the another webinar. And thank you all the participants for joining us. We were almost we were full, and we were getting requests to take them in, but we had the capacity of 100 people only, so we were able to join.
Yeah, we had 100 people at one point and we could not take any more.
Yeah.
So, but thank you, ma'am. And on behalf of AOI Vidarbha and AOI and HNS Vidarbha, President Dr. Ajay Deshpande and Secretary Dr. Disha Mithwani, thank you once again.
Thank you, Gauri.
Thank you, madam.
Thank you so much.
Thank you. Bye.
Good night.
Good night.
Bye, ma'am. Good night.